Dear colleagues, my name is Artis Kalnins. I am from Riga, Latvia, and title of my presentation is Chronic Total Occlusion. Let's learn from some challenging cases. This is my disclosures. According latest European revascularization guidelines, in case of CTO, revascularization strategies should be the same like in any other lesion. That means that the rationale for CTO revascularization is clear, it's symptoms relief and prognosis improvement. With symptoms relief, we understand improvement of quality of life. With prognosis improvement, we understand decreases in mortality. What about evidence about it? A lot of data has been accumulated over the years from non-randomized comparative studies. All we know is that registries and studies are very different. We can compare medical treatment versus invasive treatment, successful cases versus unsuccessful cases, complete versus incomplete revascularization. But if you look on all these trials, the tendency is clear. In most of them, patients after CTO PCI have benefit. Here you can see data from Scandinavian Angioplasty Registry, very big registry, more than 14,000 people. We clearly see that patients without CTO have significantly better prognosis. If we compare successful and unsuccessful cases, also we can see big gap between these two lines, and of course better results have patients after successful CTO revascularization. This is a slide from other study done in Germany, but Grosingen. In this study was included CTO patients as single vessel disease patients, and these patients was compared with CTO patients who was multi-vessel disease patients. Also, we clearly see better results after successful CTO revascularization. Especially, results was better in multi-vessel disease group. What about randomized clinical trials? 2 years ago was published data from EuroCTO trial. For 2/3 of CTO patients in the trial was done PCI. 1/3 of patients was included in medically treatment group. What was found in follow-up? Much better results have patients in invasive treatment group. They have better quality of life, they have less angina, and patients was more satisfied with treatment. Especially good results was found if we look on angina relief. That confirms once more that symptoms is the main indication for CTO PCI. What about clinical trials and prognosis improvement? In 2019 was published data from Decision CTO trial. Aim of this trial was try to understand prognostic importance of CTO revascularization. Unfortunately, 3 years data didn't show any difference between PCI group and medical treatment group. Yes, this trial has been criticized a lot about patient selection, about overlapping between groups, about a big number of stents in medically treatment group, but results are very clear. We really don't see significant difference between two treatment strategies. Unfortunately, at this moment, we don't have randomized clinical trials confirming prognosis improvement as CTO PCI indication. Collaterals is a typical finding in CTO cases, and additional questions about collaterals is, do collaterals matter? Answer is definitely yes, because collaterals may affect patient symptoms and prognosis, and in most of cases, collaterals determine invasive treatment strategy. If you look on three most popular CTO treatment algorithms, hybrid American algorithm, European Euro-CTO Club, and Japanese algorithm, we see that collaterals play significant role in all these algorithms. Presence or absence of collaterals available for retrograde approach recommends for operators to use one or other strategy, to go antegrade or to go retrograde. This is an interesting study published recently in Euro Intervention about collaterals. In this study was included 250 patients, and all patients was divided in two groups. Excuse me. Patients with well-developed collaterals and patients with poorly developed collaterals. For all patients was done MRI examination. What was found? We have traditional opinions that patients with Q waves on ECG have transmolar scars. On this study, only in 5 to 10% of segments was found scar tissue. That means that infarcted area and myocardial subtended by a CTO is generally limited. Also, was found that patients with well-developed collaterals have less scar tissue. That means that well-developed collaterals may affect patient prognosis and can save myocardium. At the same time, viability was regularly present also in patients with poorly developed collaterals. And these patients was found in this trial have big potential for functional recovery. Sometimes Q waves on ECG and absence of well-developed collaterals is reason why we refuse to do CTO PCI. Yeah, but this study showed that maybe these patients have more potential for recovery than patients who had no myocardial infarctions. Last not least, this question about complications. All we know that CTO procedures is high-risk procedures. Here you can see data from Euro-CTO Club registry and Progress CTO registry. If we compare antegrade and retrograde cases, we clearly see that retrograde approach have more complications, especially perforations. Does it mean that we must avoid to use this method? Definitely no. If we look on the data from this Progress CTO registry, we clearly see that retrograde approach is not a method of choice for any case. Retrograde approach we mostly use in more complex cases with GCTO score 3, 4, and 5. Another important thing is operators' experience. Manos Brilakis analyzed CTO PCI cases done in the United States, and he found that operator CTO PCI volume is associated with procedure success and complications. Operators doing more than 50 cases per year and doing more than 100 have success rates near 90%, and at the same time they have a very low number of complications. Finally, two interesting cases. My first case is 42 years old male, smoker. Patient underwent myocardial infarction 1 year ago. was done PCI for right coronary artery, and also was found LAD chronic total occlusion. Exercise and stress echo tests was positive, and I decided to do CTO PCI. Here you can see right coronary artery with good result after angioplasty. And also we can see LAD proximal occlusion and diffuse disease in middle part of LAD. I started this case with antegrade approach and tried to cross this occlusion with Schilder XT and Gaia second wires. But I couldn't reach true lumen. One option was to continue this procedure with dissection re-entry, but as we know, it's not a good option for LAD. And other things that patients have diffuse disease in middle part and relatively bad landing zone. And I decided to continue this case with retrograde approach. I cross one of septal collaterals with Sion black wire and Thornpike LP microcatheter. I crossed occlusion retrogradely. It was not difficult. I did externalization, and my idea was put antegrade double lumen microcatheter and with antegrade wire try to find distal LAD. But it was not possible because I found that patient have one other occlusion in middle part of LAD. I didn't want to continue this procedure with dissection re-entry. I decided to try to find another collateral more distal. I check epicardial collaterals, but these collaterals was too tortuous and too small. And finally, I find one more distal connection and cross it with second Sion black wire. I did second externalization. Before that, this second occlusion was crossed by reverse cart technique. I put double lumen microcatheter on antegrade wire, did dilatation, and here you can see final result after 3 drug-eluting stent implantation. All side branches are opened, and finally I had good TB3 flow. My second case is 65 years old male with stable angina and very long previous history. Patient underwent myocardial infarction, was done cabbage and PCI for venous graft to right coronary artery. And because patient have progressive, slowly progressive angina, we repeat coronary angio. It was found diffuse atherosclerosis, all native coronary arteries was occluded. Patient had relatively big intermediate branch with significant lesion and only one open graft. But this graft was okay without significant lesions. Here you can see native coronary arteries, LCX, LAD occluded, significant lesion intermediate branch, and right coronary artery also proximally occluded. Also, we can see epicardial collaterals from proximal RCA to LCX and LAD. Here you can see last remaining venous graft to right coronary artery and collaterals from proximal right coronary artery to left coronary system. Because patient underwent anterior wall myocardial infarction and have hypokinesia on LID, I decided don't touch LID, but try to open LCX. I started this case with antegrade approach with parallel wire technique, but I couldn't reach distal through lumen. After that, I decided to go for retrograde, and fortunately, the biggest size collateral one was only this very tortuous epicardial from proximal right coronary artery. But no, despite this tortuosity, I decided to try to cross this collateral. I started this case with serum black wire and Torpac LP microcatheter, and it was a surprise for me that despite very bad backup support for guiding catheter, collateral crossing was relatively easy. Here you can see real-time images. After that, I advanced my microcatheter till distal end of right of L6 occlusion. Was done proximal predilatation, and I crossed this lesion with reverse cart technique. Here you can see externalization, and this is the final view after predilatation and after stent implantation. My take-home message is main indication for CTO PCI is symptoms relief. Anatomy and collaterals determine CTO invasive treatment strategy. The retrograde approach is one of the basic methods of invasive treatment of CTO. Thank you for attention.